Hey guys, during my second year of medical school, I would notice that sometimes the classes would really get bogged down in details and sometimes miss the big picture. So the purpose of this video is really to give you a broad understanding from start to finish of hemoglobin synthesis and degradation. As we go along, be sure to categorize the different enzymes, compounds, and diseases into the different stages where they can occur. For example, know that where things occur during synthesis as opposed to degradation. And also know where the different stages occur within the cells and throughout the body. So I'm going to start off with normal physiology and then show where various pathologies can affect the pathways and their corresponding consequences. Starting with some dreaded embryology, let's talk about hematopoiesis. Hematopoiesis begins or occurs in the bone marrow of adults, but in fetal life, the location is very different. Hematopoiesis is going to start within the yolk sac of the embryo, and this is the key site of red blood cell production for the first 3 months. After 1 month, the liver is going to start synthesizing erythrocytes and continue on throughout birth. The spleen then has a short-lived time of hematopoiesis from the 3rd to 6 months, and then finally hematopoiesis will occur in the bone marrow. The bone marrow is one of your 2 primary hematopoietic organs, along with the thymus, remember. And after birth, 100% of red blood cell production will occur within the bone marrow. You can remember this with the nice little mnemonic of the order. So it's the young liver synthesizes blood, YLSB. So we go from the yolk sac to the liver to the spleen and then ultimately the bone marrow. Looking a little bit closer at bone marrow, the red blood cell production starts with the pluripotent stem cell, which then differentiates into a progenitor cell. This progenitor cell is a myeloid multipotent stem cell. The myeloid multipotent stem cell will form colony-forming units, which will eventually mature into your erythrocytes. The production of red blood cells occurs within the erythroblast islands, and here a central macrophage is stimulated by erythropoietin that comes from your kidneys. This drives the maturation, and also the macrophage is going to provide iron onto to the red blood cell precursors. Remember from histology that there's a series of maturation steps that the erythroblasts go through before they mature into a reticulocyte and then eventually an erythrocyte. As the erythroblasts mature, they have decreasing cell volume, the nucleus is going to decrease in size and it will eventually be extruded, along with decreasing ribosomes in mitochondria, along with all other organelles, but they will have increasing levels of hemoglobin. So RNA is going to decrease, hemoglobin is going to increase. Once enucleated, meaning it gets rid of its nucleus, the erythroblast will become a reticulocyte. A reticulocyte is simply an erythrocyte precursor that is enucleated, but still has some ribosomal rRNA left. After a few days, the RNA is lost and it becomes a mature red blood cell. One of the classic findings of red blood cell pathology is basophilic stippling, and this is due to lead poisoning. Lead causes basophilic stippling because the erythrocytes retain rRNA, which eventually precipitates out, forming little clumps known as basophilic stippling. So as you know, red blood cells really only have one job. They carry oxygen. They have no organelles, no nucleus, just hemoglobin. Hemoglobin is made up of 2 constituents, both heme and globin proteins. Heme is going to be synthesized both in the mitochondria and the cytoplasm. Simultaneously, there are globin chains that are encoded within the nucleus being transcribed, and then that mRNA is translated on into globin chains. The hemoieties in the globin chains are then combined to make different hemoglobin tetramers. Anything that affects the production of heme, like a sideroblastic anemia, for example, or the globin chains, like a thalassemia, either alpha or beta thalassemia, will result in a microcytic anemia because the erythrocyte precursors don't have enough filling, yet they'll continue to divide, causing each resulting cell to be smaller. Heme synthesis is extremely complicated, and for the purpose of Step 1 exam and other exams of your first 2 years of medical school, make sure you know the key steps of pathologies and know the rate-limiting mechanism. The first step and the final 3 steps occur within the mitochondria, whereas all the other steps occur in the cytoplasm. The first step of heme synthesis is also the rate-limiting step. This is the first step where delta-aminolevulinic acid synthase converts succinylcholine from the citric acid cycle and glycine to delta-aminolevulinic acid. So this is the rate-limiting step, and B6 is a required cofactor for the enzyme ALAS, aminolevulinic acid synthase. Since this is the rate-limiting step, ALAS is tightly controlled by both positive and negative feedback. There's negative feedback inhibition, which can be accomplished by heme, hemin, and glucose, whereas in contrast, certain drugs can actually induce aminolevulinic acid synthase, including the CYP450 drugs like the barbiturates, alcohol, and smoking. After this first step, delta-aminolevulinic acid is transported into the cytoplasm, where aminolevulinic acid dehydratase can convert delta-aminolevulinic acid onto porphobilinogen, or PBG. Porphobilinogen is then deaminated by porphobilinogen deaminase into hydroxymethylbilane. This hydroxymethylbilane is then converted to uroporphyrinogen 3 via uroporphyrinogen 3 synthase. The enzyme urod, or uroporphyrinogen decarboxylase, then converts uroporphyrinogen onto coproporphyrinogen 3. That coproporphyrinogen then re-enters the mitochondria, where coproporphyrinogen oxidase makes protoporphyrin. This protoporphyrinogen. Protoporphyrinogen is then converted onto protoporphyrin, and then the final synthesis in heme synthesis is accomplished by the enzyme ferrochelatase. Ferrochelatase then combines that protoporphyrin that we just saw made along with an iron, and that makes heme, and this will ultimately provide negative feedback onto aminolevulinic acid synthase, the rate-limiting step. So, as you would have guessed, since this is such a complicated pathway to make heme, there's got to be a lot of different pathologies that can affect this pathway. So sideroblastic anemias are a large collection of conditions where there is a microcytic anemia due to a defect in heme synthesis. Specifically, this affects protoporphyrin production. A sideroblast is when you have an erythroblast, or a red blood cell precursor, that has iron building up within the mitochondria due to defects in incorporating that metal into the porphyrin ring to make heme. The macrophages of the hematopoietic islands will continue to pass this iron to the erythroblasts, but it can't be utilized. Thus, iron is going to build up within those mitochondria and can be seen on a bone marrow biopsy. And so just break down the word and it helps out. You have a sideroblast, sidero meaning iron, and blast referring to a precursor cell. So a sideroblastic anemia, therefore you have these precursor cells that have iron buildup in the mitochondria around the nucleus, forming a little ring. Sideroblastic anemias can either be hereditary or they can be acquired conditions. The hereditary sideroblastic anemia is a congenital condition, and this is an X-linked recessive loss of delta-aminolevulinic acid synthase, the first or rate-limiting step, as you remember. You can also have an acquired sideroblastic anemia that can either be due to alcohol. Alcohol is a general mitochondrial toxin, and it can also be due to lead poisoning or vitamin B6 deficiency. Lead poisoning affects many of the steps in heme synthesis, but for the purpose of MBMA, it mainly affects two different enzymes. Lead is going to block the step of aminolevulinic acid dehydratase, the second step, and also ferrochelatase. This will lead to the buildup of aminolevulinic acid and also zinc protoporphyrins, which is the second to final step, respectively, based on the enzymes. Lead poisoning will show a microcytic anemia with basophilic stippling. So what this is our RNA is retained within the cytoplasm. Be sure not to confuse basophilic stippling on a blood smear with sideroblasts seen on a bone marrow biopsy, although both are seen in lead poisoning. Lead poisoning will also show many systemic symptoms, and it varies depending on the age. In kids, lead poisoning is typically due to lead paint exposure. Kids will have neurological problems and also low IQ. Think about Flint, Michigan in the news. I'm sure you guys have heard of that. And in contrast, adults normally get lead poisoning from occupational exposures like lead batteries or ammunition. The systemic signs in adults are going to be headache, memory loss. You can also get a demyelinating peripheral neuropathy, like the classic wrist drop, and you'll see that in questions. And also lead lines in the bones and the gingiva, along with abdominal pain and even renal problems. The renal problems are typically a chronic tubulointerstitial disease. Be sure to note that the lead lines that we talk about in lead poisoning are radiodense epiphyseal deposits, meaning they're bright white on X-ray. They're at the ends of the bones, but this is due to calcified cartilage and not actually lead building up. Sideroblastic anemias can also be acquired due to a deficiency of vitamin B6, and this is most commonly seen in with the use of isoniazid treatment for tuberculosis. B6 deficiency leads to a loss of the rate-limiting enzyme, which is aminolevulinic acid synthase, since B6 is a necessary cofactor of aminolevulinic acid synthesis. All of the sideroblastic anemias will have very unique findings on blood tests that will help you distinguish them on test questions for a microcytic anemia. So if you see a microcytic anemia, typically, and sideroblastic anemia will show an iron overload state. Patients will have elevated ferritin stores, low total iron binding capacity, high serum iron, and high transferrin saturation. And the key that really you need to remember is that they do not have an iron deficiency. Any time that your ferritin stores are high, your total iron binding capacity will be low. And so these patients have high iron, and that's not the deficiency of iron is not the cause of their anemia. It's something like alcohol, it's X-linked, it could be B6, or it could be due to lead poisoning. Another major class of pathologies we can talk about in heme synthesis pathway are the porphyrias. The porphyrias are also either hereditary or acquired conditions, and in all porphyrias there is a defective heme synthesis enzyme causing a buildup of the upstream precursors. Lead can also show similar effects because it inhibits different heme synthesis enzymes. When looking at the porphyrias, there's a key dichotomy to remember. Anything that affects the steps before hydroxymethylbilane will cause a visceral porphyria since there are no protoporphyrins made, therefore there's no photosensitive rash. In contrast, anything after hydroxymethylbilane will cause a cutaneous porphyria since porphyrin rings are made, and those will be deposited in the skin causing a photosensitive rash. So talking about the steps before hydroxymethylbilane, we have acute intermittent porphyria. This is the second most common type of porphyria. Acute intermittent porphyria is a loss of porphobilinogen deaminase. This will cause a buildup of porphobilinogen and also coporphobilinogen, which is a porphobilinogen metabolite that I don't have drawn out. And those will be spilled out into the urine. Patients with acute intermittent porphyria will have no skin findings nor a photosensitive rash. Instead, acute intermittent porphyria will show the 5 classic Ps, which includes abdominal pain, port wine urine, as porphobilinogen and coporphobilinogen are spilled out into the urine. Patients will also have polyneuropathies, along with psychological disturbances like being aggressive or irritable, and it can also be precipitated by the CYP450 inducing drugs, along with smoking and alcohol. And so the treatment is mostly abortive, and you can use glucose or hemin to inhibit aminolevulinic acid synthase, the first step. Another porphyria that you should know for the purposes of boards is porphyria cutanea tarda, and this is the most common porphyria. Once again, this is after hydroxymethylbilane, so now this is a cutaneous porphyria. Porphyria cutanea tarda is a defect in urod, which is uroporphyrinogen decarboxylase, and this will lead to a buildup of uroporphyrinogens that spill out in the urine. Patients with porphyria cutanea tarda will present with like a photosensitive rash, and also brown or dark tea-colored urine, which will actually fluoresce bright pink under a Wood's lamp. Also, patients will have hypertrichosis. Hypertrichosis is where you have an excess of hair on the face. Typically, it's a finer and lighter colored hair up on the nose and even up the temples, so places where hair should not be male or female. And be sure not to confuse hypertrichosis with hirsutism. Hirsutism is male pattern facial hair, just in a female, whereas hypertrichosis is this like finer, thin, light hair all over the face. Porphyria cutanea tarda will not have any visceral pain, like acute intermittent porphyria. And for the purposes of these porphyrias, make sure you can recognize the symptoms of both acute intermittent porphyria and porphyria cutanea tarda, or also things like lead based on occupational exposures. Board exams will not actually tell you the diagnosis. Instead, they'll describe how the patient presents and ask about the enzymes that are deficient or products that will build up. It's not enough to simply know the associations, so make sure you can recognize those. After the red blood cells mature, they're going to be pumped around the body, carrying oxygen from the lungs out to your tissues. Erythrocytes have a half-life of about 120 days before being cleared from the system. The spleen is a very large secondary hematopoietic organ that's composed of both white and red pulp. Looking a little bit closer at the red pulp, it's composed of splenic cords and the venous sinusoids. The venous sinusoids are going to be filled with blood, and the red blood cells must navigate through those splenic cords before leaving the spleen. Any senescent red blood cells or cells with other underlying pathologies like hereditary spherocytosis cannot pass very well through the red pulp of the spleen, where they're phagocytized by and then ultimately removed by your splenic macrophages. Within the macrophages, red blood cells are going to be degraded into their individual constituents. Hemoglobin is first degraded into heme and globin components. While the globin protein can be broken down and recycled as amino acid monomers, the heme is a toxin that's a degradation product and must be removed from the body. The first enzyme that works on this is heme oxygenase, and that degrades heme into biliveridin and also iron. The iron from the splenic macrophages is efficiently recycled, just like the globin amino acid monomers. In contrast, biliveridin is then converted by biliveridin reductase to bilirubin. Bilirubin can't be recycled, and it's a toxic metabolite. It's also dead end and must be excreted. The splenic macrophages produce unconjugated bilirubin. Unconjugated bilirubin is very lipid soluble, and recall from pharmacology that highly lipid soluble molecules are passively reabsorbed through the kidney and cannot be excreted in the urine. Therefore, the liver must act as a conjugation site to allow bilirubin to be excreted as a more polar molecule. Be sure to remember that unconjugated bilirubin is also referred to as indirect bilirubin, whereas conjugated bilirubin is direct bilirubin. This naming refers to the laboratory analysis of your serum bilirubin, and those different terms can be interchanged. So unconjugated bilirubin is released from splenic macrophages out into the serum. Since it is highly lipophilic, it must be bound to a carrier protein, and in this case it's albumin. Since unconjugated bilirubin is both protein bound and highly lipid soluble, it can't be excreted in the urine. Unconjugated bilirubin is therefore taken up from the hepatic sinusoids and by the hepatocytes and conjugated to a glucouronic acid by the enzyme UGT, or uridine glucouronyl transferase. By adding the glucouronic acid to the bilirubin, it's now conjugated in a much more water-soluble version and can be excreted out into the bile, where it's stored into the gallbladder before being released into the second part of the duodenum. This conjugated bilirubin can then pass through the small intestines, where approximately 80 to 90% is lost in the feces. In contrast, a small fraction of about 10 to 20% will be deconjugated to urobilinogen. Urobilinogen then has two fates. Majority of urobilinogen, about 90%, is going to be oxidized by your normal gut flora, and this will become stercobilinogen. Stercobilinogen is brown and gives feces its brown color. In contrast, a small amount of urobilinogen, around 10%, is absorbed by the terminal ileum, just like your bile salts, to be recycled. Urobilinogen is therefore present in the portal venous blood. Urobilinogen can then undergo enterohepatic recirculation and then be retaken up by the liver, reconjugated, and then excreted, or it can be converted to urobilin. Urobilin is more water-soluble and can actually be excreted by the kidneys, giving urine its color. About 10% of all urobilin reabsorbed is excreted by the kidneys. It's very important to realize that if conjugated bilirubin is not excreted through the biliary tree into the gut, then the feces will not have any color, and we'll talk about that more with the pathology of jaundice. Similarly, if no conjugated bilirubin is put into the gut, then it will never be converted to urobilinogen and it won't be absorbed from the ileum. Therefore, there will be absent urobilinogen in the urine. So now that we've talked about hemoglobin degradation, let's talk about what happens when things go awry. So this, of course, is going to cause jaundice when you have a buildup of these degradation metabolites. Jaundice is a symptom due to elevated levels of serum bilirubin, and typically once those bilirubin levels are going to be greater than 2.5 milligrams, whether it's conjugated or not, you're going to see jaundice. Jaundice is first seen in the sclera of the eyes, and then next is seen as a skin discoloration to a yellowish pigment. Jaundice comes in three main forms. It can either be due to elevated unconjugated bilirubin, and elevated conjugated bilirubin, or mixed, which is both unconjugated and conjugated. It's pretty a good idea to categorize these diseases and learn them in the context of the three categories in order to keep them differentiated. Board exams love to test these since they integrate both the normal physiology of heme synthesis and metabolism and also pathophysiologies. A predominantly unconjugated bilirubinemia, which is just high bilirubin within the blood, or jaundice, is where less than 20% of the bilirubin is indirect or unconjugated. Unconjugated bilirubinemias can either be due to decreased uptake or decreased conjugation ability, or it can also be due to excess production of unconjugated bilirubin. In either case, the labs are going to show elevated bilirubin with at least 80% or more being unconjugated. Recall that all unconjugated bilirubin is circulating in the blood bound to albumin. Within the liver sinusoids, unconjugated bilirubin is going to be taken up into the hepatocytes and then conjugated to a glucouronic acid by UGT before being excreted into the bile canaliculi. Gilbert syndrome is one of the most common hereditary jaundices and the second most common cause of jaundice overall, only second to viral hepatitis. Gilbert syndrome, also known as familial non-hemolytic jaundice, is an autosomal recessive decrease in UDP glucouronyl transferase activity with or without impaired bilirubin uptake. Gilbert syndrome is typically asymptomatic, but it can also have mild jaundice in the presence of stressors like illness or fasting. So remember that glucose is going to inhibit aminolevulinic acid synthase in heme synthesis. So when you're fasting and you don't have glucose, you disinhibit it. Gilbert syndrome is clinically insignificant and there is no treatment needed, nor do you need to do a biopsy. The diagnosis is presumptive based on the symptoms and also the absence of other labs. So all other labs like AST, ALT, along with alkaline phosphatase and GGT are going to be normal. Crigler-Najjar type 1 is a much more severe cause of elevated unconjugated bilirubin due to an autosomal recessive absence of UGT. Crigler-Najjar is fatal within the first few years of life since there is marked elevations of unconjugated bilirubin, which is highly lipid soluble and therefore can collect in the brain, causing kernicterus, especially in the basal ganglia. This is essentially jaundice of the brain. The treatment for Crigler-Najjar is a combination of plasmapheresis and phototherapy. There's a second type of Crigler-Najjar known as Crigler-Najjar type 2. This is very similar to Gilbert syndrome. It's less severe than type 1, and treatment is actually based on phenobarbital, which will induce UGT. It's one of the cytochrome P450 enzymes, and phenobarbital, as you know, is a CYP inducer. Another reason that you can see an unconjugated bilirubinemia is a physiologic jaundice of the newborn. This is a transient condition due to low activity of the neonatal liver, and there's a poor conjugation ability due to low activity of UGT. Physiologic jaundice of the newborn starts at about 24 to 72 hours after birth and will last up to a week. Treatment is actually based around phototherapy. Phototherapy can convert unconjugated bilirubin into a more water-soluble photoisomer that can then be excreted into the urine. Rarely will unconjugated bilirubin levels be high enough to cause kernicterus and any damage. And then the final cause of decreased conjugation is due to breast milk jaundice. Breast milk jaundice is a condition caused by a substance that's present in breast milk known as pregnane 3-alpha 20-alpha diol, which is going to inhibit neonatal UGT. Breast milk jaundice is going to start about 4 to 7 days after birth, so a little bit later than physiologic jaundice, and will rapidly revert after cessation of breastfeeding. Be sure not to confuse breast milk jaundice with breastfed jaundice. Breastfed jaundice is going to start within the first 3 days of life, just like physiologic jaundice of the newborns, but it's more due to low intake of milk, not an inhibiting substance. This is thought to increase the enterohepatic circulation of bilirubin in breastfed jaundice due to low intake. And the treatment is actually to increase the fluid intake to decrease this enterohepatic circulation. In contrast to breast milk jaundice and physiologic jaundice of the newborn, breastfed jaundice will have increased urine urobilinogen since there is increased enterohepatic circulation. It is not due to decreased conjugation abilities. In terms of labs for the unconjugated hyperbilirubinemias, all jaundices due to decreased uptake or conjugation of bilirubin. There will be elevated unconjugated bilirubin, of course, that's part of the name, in the serum, but you'll also have absent urine bilirubin. Unconjugated bilirubin is lipophilic and it will not be excreted. And also you will see low urine urobilin. Since no conjugated bilirubin is being put into the gut and converted onto urobilinogen, it can't be reabsorbed and excreted. If you know the mechanisms of each of these conditions, it's very easy to derive what you should see on the labs. An elevated unconjugated bilirubin can also be due to increased production of unconjugated bilirubin in cases of extravascular hemolysis like hereditary spherocytosis or ineffective erythropoiesis like a thalassemia where the red blood cells are actually degraded before entering circulation. When there's an increased production of unconjugated bilirubin, it's going to overwhelm the normal liver conjugating capacities and levels are going to build up in the blood. Labs are going to show, once again, elevated unconjugated bilirubin, and urine bilirubin levels will still be low since that unconjugated bilirubin is lipid soluble and there is just an increased production. But while you're increasing the production of unconjugated bilirubin, you have normal conjugating abilities, there's going to be increased conjugated bilirubin being put out into the gut. Therefore, you're going to have increased urobilinogen produced in the gut, which is going to be reabsorbed and subsequently lost out in the urine. Therefore, urine urobilin is going to be elevated due to increased production. Remember that in extravascular hemolysis or ineffective erythropoiesis, you can be at high risk for pigment gallstones due to increased levels of conjugated bilirubin being put into the biliary tree, and that will lead to your pigment stones. Mixed jaundice or mixed bilirubinemias are going to have 20 to 50% conjugated bilirubin levels. The major cause of mixed jaundice is viral hepatitis. This is the most common cause of any jaundice. In viral hepatitis, there's inflammation, and this is going to disrupt the normal hepatocytes in the small bile ductules, resulting in elevations of both your conjugated and unconjugated bilirubin. Lab findings are going to show an elevated urine bilirubin because you have that water-soluble conjugated bilirubin that's elevated, so that can be lost in the urine. And also patients can present with dark urine because of these elevated levels of urine conjugated bilirubin. In terms of urine urobilinogen, it is variable based on the length of the time of the hepatitis. Initially, you're going to see an increased urobilin level, and then later you're going to get decreased levels of urobilin in the urine. This makes sense if you understand the physiology of bilirubin, because the majority of reabsorbed urobilinogen is subject to enterohepatic circulation. And since in hepatitis the liver is inflamed and has decreased uptake of urobilinogen, it's going to spill out in the urine. As the hepatitis continues to persist, the decreased bile flow is going to lead to decreased production of urobilinogen within the gut, and then there's a subsequent decrease in urine urobilin, although urine conjugated bilirubin will remain high. In viral hepatitis, you can also see other additional lab findings that really help you clue into the diagnosis, and this will be the markers of hepatic damage, and this will be like elevated AST and ALT. And then the final category of conjugated bilirubinemia, in which over 50% of your elevated bilirubin is conjugated. So in conjugated bilirubinemia, over half is conjugated. Elevated conjugated bilirubinemia can either be due to obstruction or it can be due to inherited conditions. The obstructive jaundices can either be intrahepatic, which is most commonly due to certain drugs like oral contraceptives, or it could be due to a disease like primary biliary cirrhosis, also known as primary biliary cholangitis. Obstructive jaundice can also be extrahepatic due to gallstones, tumors, whether it's in the pancreatic head, like a pancreatic carcinoma, or a cholangiocarcinoma, which is of the biliary ducts. It also can be obstructive extrahepatically due to parasites or the liver flukes, like Clonorchis sinensis. All end up blocking bile flow, resulting in cholestasis. Cholestasis is simply the failure of bile to flow. In obstructive jaundice, there will be additional serum findings of elevated alkaline phosphatase and GGT. These are both markers of cholestasis. Alkaline phosphatase is a little bit less specific, but GGT as a follow-up or gamma glutamyl transferase can verify that it's of bile duct origin. In obstructive jaundice, patients can present with pale acolic stools because there is no conjugated bilirubin being put out into the gut. So if you think about it, the gallstone or something like that blocking the bile ducts, no bile is going out into the duct, and there's subsequent loss of production of stercobilin. Additionally, patients will have dark urine due to elevated conjugated bilirubin, which is much more water-soluble, but low urobilin in the urine, because once again, no conjugated bilirubin in the gut means no urobilinogen is being produced. A common symptom of cholestasis or obstructive jaundice, like in primary biliary cirrhosis, is itching due to buildup of bile acids spilling out into the blood, and also hypercholesterolemia because of decreased cholesterol secretion in the bile. Elevated conjugated bilirubin can also be due to inherited causes, and these are fairly rare autosomal recessive diseases, and this includes both Dubin-Johnson syndrome and Rotor syndrome. And these will have mildly elevated conjugated bilirubin in the serum and slightly raised urine conjugated bilirubin. These are not as severe as like a true obstruction. They're just decreased levels of conjugated bilirubin transport. Dubin-Johnson syndrome is a defect in the intrahepatic bile duct secretions of conjugated bilirubin through the apical canalicular membrane. Therefore, there's a buildup of conjugated bilirubin which is going to spill back out into the blood. While Dubin-Johnson is a completely benign condition, patients can have a grossly black liver, and typically this is an incidental finding due to the buildup of black pigments within lysosomes of the hepatocytes. Be sure to note that this black pigment is actually not conjugated bilirubin. Rather, it's a separate pathophysiology of Dubin-Johnson syndrome that causes a buildup of catecholamine metabolites within lysosomes, like epinephrine breakdown products. And then finally, Rotor syndrome is very similar to Dubin-Johnson, as there is a defect of secretion of bilirubin across the canalicular membrane. But in Rotor syndrome, the liver is not going to be grossly black. So hopefully this video helped you really get a great overview of everything going on, and you can kind of see where these different pathophysiologies fall into place and give you a kind of a backbone to start working as you clue into more of the details as you go on through pathology.